Welcome back to our Women Crush Wednesday interview series. I'm Mansi, and today I'm here with the lovely Dr. Julia Thompson, who is a consultant neurologist. What are some equity issues that you feel strongly about, and what can we as medical students do to address them, and in the future as doctors as well?
There are so many, let me say, and look, they're not new. Inside of medicine, focusing on the medical bit first, the biggest thing that you'll notice in Australia when you're working is there's a huge divide with regional and remote versus metropolitan. And I grew up rurally, and so a lot of people used to tell me, "Oh, well, you grew up rurally, you must go and work there one day." Now that's great, but I don't want to live rurally. I've done that, and yet my friends, they moved back. That's the beauty of being an individual. We may or may not want to do something, but a lot of these places do not have the same access to the center of Sydney. There's no such thing as getting upset that you can't get in that week to see a specialty. It might be months, or you may not even have specialty availability or the ability to get to a center or even know where to start. We do have to remember that, and it seems like it's not an equity issue, but it's a huge one because it's right under our noses just because people choose to live in different parts or even just different parts of Sydney. As a result, and I hope 2020's taught a lot of people this, then there's more than one way of doing something. If someone somewhere doesn't have permanent doctors moved there or can't, then why not try fly in, fly out? Why not offer telemed services? Why not, when you're a registrar or a young consultant or whatever you do, why not actually make efforts to provide a service? It doesn't have to be the ideal. No one said it was the ideal, but the ideal might not come for 20, 30 years. And in the meantime, if you can still give something, that's better than nothing. You don't have to move somewhere. A lot of people go, "Oh, I couldn't move rurally." All right, then don't. But I'm sure you can get on a plane as easily to some of the remote or rural areas as you could when you want to go to holidays in Saint-Tropez. And the big key is actually to remind people that there is ways of doing it. We were able to do so much online this year that surely there would be a way of providing it. That equity also goes for gender. And unfortunately, even in 2020, it pains me that this is still the case. Now, the thing is that gender extends, it's not just men versus women, of course. And that's something that I love when people go, "Women in medicine talk." What about the fact that it's not just men and women? Because we sort of have to remember it's all genders. There's so many different components to this. But as junior doctors, as medical students, I would say to men and women both, don't get me wrong, whether cis, whether trans, it wouldn't matter. Don't let anyone tell you that a specialty is family friendly, because why is that a women's issue? Why is that, oh, you're cis woman, so therefore, you're going to be doing a family friendly career? Why can't a man also want to work and also have co-parenting responsibilities? And so these ideas, these gendered discussions need to be thrown out, because everyone deserves the right to tailor the job. Now, there will be family-friendly workplaces. That's different. That's, that particular workplace may not enable training programs, but another one will. But we all need to abandon the idea that some specialties are for women more so than men and vice versa, or that their gender makes a big difference to who and what you are as a doctor. A lot of the time, women, obviously, patients try and spend longer with. So the problem is they're often paid less because they spend more time. They don't see as many in the same time frame. They often see the bulk billing patients where our male colleagues don't. And we need to change this idea and culture in the community that a woman's time is obviously perceived as just as valuable because patients will spend longer. So the truth is, then we should ensure that they're paid the same, and that patients know that they're paying the same, and that everyone is seeing the same sets of patients and is paid very similarly, because the pay structure entices certain people into certain things. And it might be that as a result, there's this skewed gender problem that we're getting at a consultant or hospital level. And we don't want that in 20 years. Now that women make up just as many, if not more, med students, it would be embarrassing to be sitting here in 20 years and hear that the consultants at all the hospitals are still mostly men. Right now, it's because of, 20 years ago, most of the med students were. But we have to make sure that changes. We do have to make sure that women have an equal voice, but so too do men. And that if they want parental leave, they can have it. And that there isn't actually this idea that it has to do with family or something's too hard or too longer hours. I mean, women are supposedly able to be mums and work full time. So I imagine they know what hard work is like. Honestly, when you do work in them, a lot of women find surgery very family friendly. I have not worked in a hospital where I've ever had a problem if I've said I've just got to go and do something that's related to family or myself, because, not doing it 99% of the time, we're still hardworking, but it wouldn't matter if my male colleague did either. It's the perception that needs to go. The other thing that's very prominent in neurology is disability. So a lot of our conditions have stigma. Worse in psych for sure, but neurology is right up there. And a lot of people go, ugh, neurology as well, because they're thinking of diseases like motor neuron disease and they're thinking, oh, okay. And there's these preconceived conceptions of what patients will look like and what they'll be. And the problem is it actually gets fed back to the public and the patient. And patients then believe when they're diagnosed with something that they are those diseases. And I mean it, they're epileptic or they're diabetic. They're defined by the diseases themselves, which isn't the case, but it's us that have to empower them and to change workplace cultures. We have to point out they're just illnesses for which we have medical management for, but the person can be just as independent and still work, that it's not a big deal, and that they're not defined by illness. But the minute we continue to act like there may be an issue, like, oh, I'm not sure if you could work, or this, the patient themselves is then taking on our opinion. They're looking to us to be the role model on what they can or cannot do. And it's really crucial that we as clinicians empower our own patients, just as we would want to be. You don't go to see your GP in order to tell them what you want. You go because you have a question. What is this rash? Do I need immunizations? Oh my God, I think I'm dying. We've all had them, sadly to say. And the truth is, you're going there because you need their help. You want help. And I do want to point out, whenever you think, oh, I don't want to be just a GP, they're the person you go see. It's certainly the person I see. But you will find so much in medicine and in the community that diseases that same as sexuality, same as gender, they sort of place a label on someone and a preconceived notion of what that person's able or unable to do. And as clinicians, it's our role to demystify that. I have doctors who have these conditions and they don't want the world to know. They're working very safely, but they're afraid that they would lose their job or not get a job based on that. The same as actually a lot of doctors are afraid to tell them they're pregnant, and they hide it until they can't hide it anymore because they're afraid of losing jobs or missing out, when in fact, they may not, for starters. In fact, most of the time, of course, they wouldn't, but there's that small subset that might. And if we could actually empower people, empower each other, and then be able to say it and have people come out and go, well, I have that too, no big deal, then so too would culture change. And it won't happen overnight, but it has to happen at some stage. Once upon a time, these diseases were thought to be women's hysteria and things like that. But luckily, culture changed. And now they're known to be diseases that need medical care. And they're expanding to be genetic and antibody driven. And if all people do is challenge the concepts, challenge the ideas, then medicine moves forward, as does society. We know this from all of the other issues like climate change, but we can't fix all of those as an individual. What we can do is fix the life for the patient in front of us.
Finally, do you have any advice in general for female medical students?
Look, I probably harped on so much as it is, but I would say then one thing is that listening to advice is fine. So I'm offering, I guess, general advice. But when someone wants to tell you at any point what you should do, I take everything as advice rather than actually listening too hard to it. Everyone might be very well-meaning, but there's only one person who gets to choose what you do in your career. And the biggest thing is to try and block so many of the other external voices out. The people that tell you it should be done this way, you have to get the PhD to do something. I mean, there's this funny concept that you need a PhD to do something, or you need a certain experience at a single hospital in order to get a job at that hospital. Or if you do an internship at one place, you can't do residency at another. I mean, these are all not correct. And the ideas come from other people sort of instilling that that's how they did it, so that must be the only way. You block it out. There's a way you do it is the way you do it. You don't know that you can't. You have to apply and find out. You should do what you want to do. You may not be naturally brilliant at what you want to do, but believe it or not, in medicine, you can just work really hard and still be good at something. You don't have to be born gifted in a thing. That's more a hobby. You're born gifted in your talents. You're not necessarily born gifted in a specialty of medicine. In your level, and I've been there, we've all been there. There seems like this treadmill you have to all get on that always puts you out at a certain space, and you have to be in this hospital to get hired at it. Well, I'm a consultant at a hospital I'd never worked at until I was a consultant. And that seems fine. It's great. I get to meet new people. Don't worry if you don't know what you want to do. My biggest thing is, who cares? You'll find something. There's so many features in medicine. Don't listen to what time you should have kids. If you want to have kids, do it when you need to do it. You will know that from you and your partner. Or if nature surprises you. Sometimes you don't, it only takes one time sometimes. So you just roll with nature. You don't choose it. Don't put it off, because what if by the time you put it off you can't do it? I know a lot of women have different experiences, but I've always worked in actually very supportive workplaces. I think I've been lucky that way. And women around me likewise have been working in very supportive situations. A lot of them work up until the day before delivery, they go back early. And I worked up until the day before, and it can be done, and it's done because of the supports that is offered. You'll all think it's because, oh gosh, people mistreat us, but sometimes, and I bet this rings true with a lot of you, it's your personality. Everyone's different. And it's all right to be that person. It's all right to be the person that takes maternity leave and takes as much as is offered. You have to do it your way. There's only you in your life. And the key really is to block out everyone else and just do your own thing. So just do what you need to do. Your work will still be there. You have till your 70s. It will still be there. You just have to go with every year and take each year as it comes. And I suppose to men and women both, be aware, even at your level of tribalism. It's this thing in medicine you'll have all seen where specialties go, oh, A&E just called me, or cardiology want to give a consult, or that person's just a GP. It's making a comment that's critical about another, because it's really just us all venting, and we all should not do it because it's leading to subconscious bullying. And it's what is often really attributable to a lot of the bullying in hospitals. It starts early too, and we all do it, and we all have to be mindful not to do it. As a lot of med students would say, I have to go to this hospital, I have to get this for internship, I couldn't be a GP, that would be terrible. And you think, oh my God, it'd be amazing. Actually, there are many times I think, oh, I wish I could have done that. But then I loved the term, except I had to see lots of kids, and I don't like pediatrics. If you loved these things, if you did them and enjoyed them, don't listen to the tribalism, because it's founded purely on people venting. It has nothing to do with anything but someone having a bad day. And it probably is just, oh, A&E, they called me. Well, so what? It's their job. Obviously, as students, you will all see it. And the tribalism then translates also into a gender issue. And they'll be, oh, what, she won't become a surgeon, or things like that. And it does sneak in there as well. And our job is to rock up and see patients and do our job and treat each other with respect. And we don't always do that, because it's sometimes a bit like high school. And we all do it. None of us are perfect on bad days. And it's about early remembering to be mindful, because actually all specialties are just as valuable. And you realize it at this end, I promise. Every single specialty is different, it's unique. There's no better or worse, and there's no such thing as one being better or worse. But you only realize it later on, because when you're junior, you're just picking up whatever information we're all throwing your way, even the bad information, even the bullying, because a lot of the bullying's not obvious. A lot of the bullying that you'll hear about is not as obvious as someone yelling at someone else in an operating theatre. Some of it's a lot more covert, but a lot more systematic, and better that it's stamped out early, and that you guys change us, change those above you. And I encourage that as well, because the more people we have pulling us up, the more people that go, oh, well, they did call, then that's good too. And it's important that that's an engendered thing for everybody.